Welcome everybody to the webinar with the title Thyroid Cancer 101. What a great title for Thyroid Cancer Awareness Month. It is September. And what a great topic to have a month before the Thyroid Cancer Survivors Conference hosted by ThyCa in Denver, Colorado, October 13th through 15th, which is available in person or virtually. And this is just a great session on the basics to help get ready for that session. Or if you're new to thyroid cancer, it's going to be a wonderful session. I'm going to start advancing some slides here. And I just want to tell you a little bit about the agenda and the format. The moderators are going to pose some general topic-related questions to our panelists, and the panelists are going to answer. At the same time, you are free to ask additional questions in the Q&A box. Please keep the questions general. Please don't share any personal information. And please note that we might not answer them immediately when they come in, and we may combine questions if there's things that are similar in nature, or if there's some sort of a recurring theme, we may combine them. And then we'll pose those questions to the panelists. We'll try to get to as many of your questions as possible in our hour together. And please note that this session is being recorded. I wanted to tell you a little bit about your hosts this evening. Dr. Ho, I'm going to ask you to talk through the charge of the American Head and Neck Society. And after that, I'll talk a little bit about ThyCa.
Excellent. Welcome, everybody. We've got a dynamite program today. Daria and I have worked to make this inclusive of everybody, and we have an amazing set of panelists that we're excited to introduce to you. So the American Head and Neck Society is a society that's focused on head and neck cancer, and we are from the endocrine section, meaning we focus on thyroid disorders, thyroid cancers, and parathyroid disease. We really focus, we work hard to advocate for our patients, but also in that vein, focus on research and education in this arena, part of the reason why we're here today. And then our members really work very heavily on surgical research and other educational initiatives to really push the frontiers of endocrine surgery. I'm going to let Daria, although she needs no introduction, discuss ThyCa, and then afterwards we'll each introduce ourselves and talk about the various institutions and backgrounds that we come from.
Okay, I'm Daria Gerald, and I'm with ThyCa, the Thyroid Cancer Survivors Association, and we are a nonprofit organization, and we're completely dedicated to supporting and educating and communicating to all the thyroid cancer survivors that are out there, whether they're newly diagnosed or well into their journey, and also to support their families and friends. Our mission is very clear: educate and support the global thyroid cancer community and invest in research. And we have a pretty big vision. We want to see a world free of thyroid cancer. So I've just introduced myself, so I'm going to toss it back over to Dr. Ho. And if you would introduce yourself a little more and then introduce our wonderful panelists.
Terrific. My name is Alan Ho. I am a head and neck surgeon from Cedars-Sinai in Los Angeles. This is probably the third year we've been doing this with ThyCa, and we are just absolutely delighted to really push to the forefront education for our patients, but also education for ourselves, because the more we understand and are informed about where our patients come from, the better off we are. We have a very talented set of panelists. I'm going to ask them to introduce themselves, and you'll see just why we have a very special group of people today. So maybe Beth will, or Dr. Cottrell will let you get started and move on from there.
You can certainly call me Beth. That's perfectly fine. Okay. I'm Beth Cottrell. I'm at Jefferson in Philadelphia. I'm a head and neck oncologic surgeon specializing specifically in thyroid and parathyroid disease, and do a lot of advanced thyroid cancer surgery here in Philly.
Next we'll go to Priyanka. Yeah. I think you're still muted, but Priyanka, maybe we can next move on to you.
Yes, hi, I'm Priyanka Iyer. I'm from MD Anderson Cancer Center, Houston. I'm an oncologic endocrinologist. I'm on the medical side. I'm not a surgeon. And I treat advanced thyroid cancer. I'm one of the providers in the FAST team, that is the team that treats anaplastic thyroid cancer and also high-risk advanced thyroid cancer. So I'm here to, answer any questions you have. Thank you for this opportunity.
Thank you, Doctor. And finally, last but not least, our distinguished Dr. Sebelik from Emory. Go ahead.
Thank you. And yes, you can call me Mary too. I'm Mary Seblick. I am an endocrine head and neck surgeon from Emory Winship Cancer Institute in Atlanta, Georgia. And I really have been privileged to focus my career on this very challenging cancer, which brings with it the blessing that when it is cured, the patient often gets to live out the rest of his or her life. So it is a privilege to take care of and be involved in the care of these wonderful patients. And I'm so honored. Thank you, Dr. Ho and Daria for inviting me to participate. I look forward to it.
And to jump off that point before we get started, I will say that although we are all like-minded and focused on the advocacy and are passionate about thyroid cancer and thyroid cancer treatment, we're all individuals. We all have different perspectives and philosophies, and we embrace that. There are many different ways to approach this disease, and you'll see that as we go through these questions today. So all of us may have different perspectives, and I think the audience should appreciate the fact that there are many different ways to skin the cat. So Daria, maybe we'll swing back to you to get started with these questions.
Okay, well, let's jump right in. First question, how many different types of thyroid cancer are there and which ones are most common?
Right. Maybe we'll have Beth start with that one just to get the ball rolling.
Sure. So the most common type of thyroid cancer is papillary thyroid carcinoma. There are multiple subtypes within that. So you may have been told that you or a loved one has a particular type of papillary thyroid cancer, and that's a little bit more nuanced. There are some that are more aggressive and some that are less aggressive. Besides papillary thyroid cancer, which does kind of begin from the actual thyroid cells called follicular cells, there is also a separate one called follicular thyroid cancer. They also derive from the same exact kind of cells, slightly different types of prognoses that come with follicular thyroid cancers. They're a lot less common. I think papillary thyroid cancer numbers are around 80%. Follicular thyroid cancers are more around the 10% range. And then we see even down from there, what used to be called Hürthle cell carcinoma, now called oncocytic carcinoma of the thyroid. And that's even more sort of rare. It actually used to be lumped in together with follicular thyroid cancers long ago. And so you can see these things kind of evolve over time as we begin to know more and more about those particular types of cancers and sort of divide them into their categories. Even more rare than that is medullary thyroid carcinoma. And that one, it tends to be more aggressive, has a completely different cell of origin, so it doesn't come from typical follicular thyroid cancer cells, and is about 4%, I think, to 6% or so of thyroid cancers. All of those that I just mentioned are sometimes termed together as well-differentiated thyroid cancers. The other category is then poorly differentiated thyroid cancer and anaplastic thyroid cancer. Those are both extremely rare and much more aggressive forms, and they look less and less like a normal thyroid cell and more like something else. So those are significantly more rare and significantly more aggressive.
Excellent. Priyanka, if I could ask you, especially because, as you said, you're part of the FAST program, I think many of our patients sometimes wonder, what do I have? And maybe a needle biopsy may or may not be able to distinguish what Beth had described. How do you approach these patients when the types of cancer is not necessarily clear?
That's a great question. So usually it always starts with an FNA, and typically if it says follicular, papillary, or oncocytic or Hürthle cell, if those are seen, especially if it's papillary, we know it needs to come out or there's a management plan for that. If it is follicular or Hürthle cell, then we want to, you could see cells and it doesn't necessarily mean it's cancer. So we can, look at the picture, how it looks, and also do some additional testing like a FIRMA or ThyroSeq, and depending on which one is preferred by the institution. And then you find out if this has malignant features, and then you suggest appropriate surgery. Now, when we get patients on my end, we sometimes see patients where it's not clear whether this is differentiated. That means, does it look like papillary, follicular, or oncocytic, or it is poorly differentiated, or anaplastic where it says undifferentiated. Those are the tricky ones, and very often in those conditions, we have to have those slides reviewed again. Sometimes we have to rebiopsy or get a larger piece of tissue that we call a core biopsy to look at it better to understand what it is exactly.
Excellent.
I'm going to jump in first with a question from my own observation, and then we have a question submitted. My question is, could you define FNA? I know that you all know what it is, but this is called 101, and we might have some people out there who don't know all of our acronyms.
I apologize for not for using
Okay.
the local term in our doctor's world, but it's basically a fine needle aspiration. It's basically just a needle that they put in to the thyroid nodule to take out, they kind of draw some cells out, and we look at it under on a slide under the microscope to analyze what kind of cells are drawn. But it's the full term is called fine needle aspiration or fine needle biopsy. But it's the standard process that patients undergo for a biopsy of the thyroid.
Awesome. And the question that we've had submitted is, I've been told by my endocrinologist that people with thyroid cancer cannot ever be considered cancer-free. Is that correct?
That's a tough one. Maybe I'll let Priyanka answer that, since it looks like an endocrinologist posed that to the patient. Maybe there's some context behind it that maybe Priyanka maybe could shed some light on.
That is a very that's a very sad observation that the endocrinologist made, and I mean, there is some truth to it, because there are patients that are disease-free or cancer-free that we call thyroid cancer survivors, where we don't see anything on imaging like ultrasound or any scans that we do. There's nothing structural. And when they do a blood test, they don't find any thyroglobulin or thyroid tissue in the blood that is detectable or seen. So technically, yes, they are cancer-free. I think the problem comes in, there's never a black and white in medicine. There's always this gray zone, which is a very large gray zone, wherein you may see something on imaging, but it is so small and it's not very clear what it is, and it is so small that biopsying it, I mean, you may not be able to biopsy it to begin with, or your blood test shows some abnormalities like a small amount of thyroglobulin, and your scan may be clean, so we don't know where that thyroglobulin is coming from since the thyroid has been taken out. So that can be a tricky situation, and that's where those patients come in the gray zone, and we cannot clearly say whether they're cancer-free or not, and only time will tell. But even in those patients who are survivors, there are survivorship clinics, or there is continued monitoring that should be done, because we never know which cancer is going to come back and when it will come back. So I'm not sure I would say that they are 100% cancer-free, but definitely it's not aggressive like the other cancers seen in the community.
I think I would say big picture, we don't want to miss the forest for the trees. I think the vast majority of our patients effectively are cancer-free, and that the cancer never shows up again, and that there's really no signs of recurrence, etc. Before we leave this question, I want to get Mary to answer, since we're focused on most common. There is some ambiguity. Can you describe a little bit more about this concept called NIF-P, which we see a lot and really scares patients, but then they're not scared, but then they're confused? And then finally, other more bewildering subtypes of papillary thyroid cancer that people see on their path report that may or may not be more risky or aggressive. If you could answer those, and I think that'll probably cover most of the different types of the common ones.
Well, thank you. Those are challenging questions, but several years ago, there was a need to describe a subtype of thyroid tumor that looked under the microscope similar to papillary thyroid cancer, but then over time was never noted to invade outside the gland or involve the nodes, and the chances of it coming back were very low. So there was a need to go into this very good end of what looked like papillary thyroid cancer and call it a non-invasive follicular variant of papillary thyroid cancer. And then further, the term cancer was taken out of that diagnosis. And it is actually a little bit, that dialogue is a little bit difficult to have because it's really good news. This is a very well-behaving tumor. And that's probably the word I end up using the most is tumor. It is not going to spread to other parts of the body. It's not going to invade or cause trouble, but yet it comes out a lot of the time because we don't know what it is before seeing that under the microscope. So I always term this as a very, very good outcome, very good news. But even the surgeons and the pathologists and the rest of us are a little bit confused about this entity, other than it's really good news. It's a well-behaving tumor.
And that
then,
well-behaving tumor has, is it NIFT-P? Is that how you say it?
NIFT-P, yes.
And what are the letters there, just for our new folks?
So N as in Nancy, I, F as in Frank, T as in thyroid, P as in papillary. So NIFT-P. And
Okay, awesome.
and it again, it's a good news kind of tumor. It's hard to call it cancer, which I try to pose in a really good light.
You know, they tell me that the people who coined the phrase and came up with the term purposely made it such a mouthful, such a burdensome, difficult descriptor that people would just get bored and just say it's not cancer. Okay, fine. But that was one of the stories about why they coined it as it was, just to make it a very boring sounding type of entity.
Well, and that's the great background, because that can be the case. I have such lovely patients who really want to know what it actually means. So I'm put in a position to really dive into it. Now, the other end of the spectrum that you asked me about were variants of papillary thyroid cancer that might have a different behavior pattern or maybe a worse behavior pattern. And one of them is called a tall cell, and tall cell sounds just like, or looks just like what it sounds like. It is a shape of the cell under the microscope. It's still papillary thyroid cancer, but some of its cells are shaped taller than a normal papillary thyroid cancer. And that may have more aggressive behavior, or maybe more likely to be resistant to other kinds of treatment. We have so much information now about the individual mutations that can be seen in thyroid cancer cells. So we're learning more about the behavior of papillary thyroid cancer cells that have very specific mutations. And it is an exciting time in the science of thyroid cancer, because we're really trying to get better at figuring out which thyroid cancers are well behaved and not going to hurt the patients over time, and which ones we need to be more vigilant and more aggressive about. And we're at a very good time in science to figure that out.
Wonderful. Thanks, Mary. So, Derry, I think we've exhausted this question. We've covered quite a bit of ground already.
Yes, so we're going to move on, and as we're moving on, I just want to let people know that I see your questions, and some of them will naturally, I think, get answered with some upcoming slides. And if they do, I'll dismiss them. And if not, I'll make sure that we circle back. So this next question, please help us understand these surgical terms: a total thyroidectomy versus a partial thyroidectomy, and then a thyroidectomy with central neck dissection versus lateral neck dissection. And when are these different surgeries used?
Great, thanks. Maybe we'll swing back to Beth to get us started on what's entailed behind each of these different surgical procedures.
Sure. So total thyroidectomy means removal of the whole thyroid. That's kind of the idea. behind that. And partial thyroidectomy usually refers to some version of taking out a portion of the thyroid. That may be removing, let's say, the right half of the thyroid. It may be removing the right half and the isthmus. It may even be, in some particular cases, removing the right half, the isthmus, which is that center portion. Sorry for not defining that term, but the isthmus, I say, is the body of the butterfly. It's kind of, or the bridge between the two lobes. It's kind of a smaller piece of tissue that sort of goes right over the windpipe, the knot in the bow tie, so to speak. And so the other possibility is having half of the thyroid, that center portion, and even a small portion of the other side potentially removed. Thyroidectomy with central neck dissection. So central neck just refers to the lymph nodes that are right around the thyroid. They kind of sit in the fatty tissue that sort of holds the thyroid in the neck in the very center. The lateral neck basically refers to the lymph nodes that are kind of in the side of the neck, and that the thyroid can have nodes that, or cancer that spreads to these nodes. And so when we have evidence on imaging, say, for example, an ultrasound or a CT scan of lymph nodes in those areas that have been affected by a metastasis, a cancer metastasis, that's when we would go in and remove those. So the kind of, to a little bit allude to sort of when are these surgeries used, the idea is basically when there is a lymph node that shows that it has been infiltrated by metastatic cancer, we want to go in and not just remove that one node, but actually remove that entire, what we call level, or that kind of area. I say the zip code. So we remove the whole zip code that lymph node is in. And so there might be multiple lymph nodes that we have to remove because there may be multiple zip codes that the cancer has traveled through in order to get to that node that we see on our imaging. Generally, as Dr. Iyer mentioned earlier, we confirm that first with a needle biopsy to prove that there's actually cancer in those nodes before going after them. So in terms of sort of when are they used, it usually is not just imaging, but also a biopsy that would have showed that to us.
Excellent. Now, Priyanka,
We have a relevant question, if I could squeeze it in, and then we jump to another doctor maybe. What's best if they find papillary carcinoma on one side of the thyroid, but they've got a multinodular situation that's affecting the other side as well, and maybe there's some family history? Would you still go for a partial, or would you recommend a total?
wow.
So I will say that absolutely
Yeah,
every, I'm sorry.
Go ahead, Beth.
I was just going to say that every patient is different, and the answer to that question will involve so many different factors, more than are just put into that question stem. So I can certainly see situations in which the best answer is removing partial thyroid, just doing half the thyroid. And I can see other situations in which taking the entire thyroid out is the right way to go. So it's really dependent upon the imaging, the types of nodules, the size of the cancer, status of lymph nodes, things like that. So
maybe before we get to Priyanka, maybe Mary, you could tell us a little bit more about your philosophy in that kind of situation. And I think it'd be helpful because many patients will get multiple opinions and get polar opposite answers for what to do. What do you think, Mary? Anything in particular in that kind of situation? It sounds like it's a bunch of patients that we've all had clumped into one. Mm-hmm.
So thank you for asking. And Beth, I completely agree with you. This is so personalized to the individual patient and circumstances. But let's look at the absolute perfect patient for taking out half the thyroid. That would be somebody with a smaller than 4 centimeter cancer on one side and an absolutely clean, normal lobe on the other side, and without a family history or other negative factors. That's like the perfect person to have just one side removed. And that's pretty nice, but not everybody fits into that just perfect category. I have patients who are very eager to retain as much of their non-malignant thyroid as they can, even if it does have nodules. And in that situation, you would intend to take out the side with the cancer, but really do some proof on the other side, such as FNA, that the other nodules are benign. Because here's the issue. Once you take out one side that has a cancer, you still have to follow for long term, for many years, you still have to follow the other side to make sure that there's not another cancer in the other side. People with a family history of thyroid cancer, that always makes the patient and the doctor a little bit more nervous about doing less than total. But I do agree. I think there are a lot of patients who are very motivated to keep a non-dangerous, but maybe nodular lobe at the same time that they get the side with the cancer removed. So it is very personalized. I just love those patients with a single nodule that has cancer and a perfectly clean other side. That's the easiest decision to make.
Priyanka, we love your opinion because in many ways you have to follow these patients much longer than we do. And maybe you could tell us a bit more about your philosophy in such a patient, both in terms of the potential need for thyroid hormone replacement and doing ultrasound surveillance for that other side. Is it a burden or is it actually okay? I'd love to hear your thoughts.
Absolutely. And it's very important to discuss with the patient regarding long-term follow-up, as Mary suggested earlier. A lot of patients don't want to deal with long-term follow-up or the fear that the cancer can come back on the other side. Or some patients are very clear that, they want their other lobe because they don't want to be dependent on thyroid hormone. And in my experience, what we've seen is there is no solid way to predict which patient with a lobectomy will end up needing thyroid hormone or not. Now, there are some studies here and there, but you may still, patients who are motivated to keep their other lobe in place, even if they have nodules, and that's what they want because they don't want to take thyroid hormone. I always counsel them that after surgery, we will check their blood work in 6 to 8 weeks to see if their TSH is appropriate, because remember, the side that was taken out had thyroid cancer. So even if it was low risk, there is a certain TSH goal it should be in. That means that the other lobe may make thyroid hormone normally, but it may not be normal for the low risk. So sometimes you may have a high normal TSH value, but they had thyroid cancer. So they may end up needing thyroid hormone anyways. But on the other hand, I also, like Mary suggested, if there's a patient with just one nodule on one side, which is cancer, and the other side is clean, I really urge them to consider a lobectomy because I don't think that total thyroidectomy is necessary. And if they don't have nodules, we pretty much, sure, we can watch it, but the long-term follow-up is not as intense as somebody with the lobe intact and has nodules. So it definitely is very patient dependent and we decide on a case-by-case basis.
Excellent. There's a lot of ambiguity when it comes to this. It sounds like even amongst the experienced panelists here, but it sounds like the ultimate answer is that there is no correct answer. It's patient dependent. All right, Daria, I think we can move on to the next question.
Yeah, and people are filling up our Q&A box. I'm keeping an eye on that.
Yeah.
Is radioactive iodine used to treat everyone with thyroid cancer? And there's a question that says, is it always used after a total thyroidectomy, and when is it not used? So I think we can answer that as we cover this one.
Okay. Maybe we'll start with Priyanka, since she is the one that many times determines the usage of iodine. So go ahead, Priyanka. Why don't we see how you would answer this?
Absolutely. Thank you. So we don't treat everyone with thyroid cancer. So the role of we don't treat everybody with radioactive iodine. The goal of radioactive iodine is really to prevent recurrence. It's not curative in any way. It doesn't cure anybody of cancer. It's basically, we use it to prevent recurrence in patients who are at risk for recurrence. It is done after total thyroidectomy. It should never be done after a lobectomy because it's not going to serve its purpose. The other lobe is going to take up all the iodine, and it's a futile test or treatment. But after total thyroidectomy, what we do is we look at the tissue itself or the pathological report on the tissue. And if the pathologist says that this person had lymph nodes which were a certain size, or if this tumor was extending outside the capsule or outside the margins were positive, if words such as that are used, or if they're invading the blood vessels of the tumor, if the pathology report has any such words, that would indicate that this tumor possibly has had some spread outside the thyroid and is likely to come back. So in those patients, we use radioactive iodine. But there are some patients, like, for example, who had a lobectomy, obviously we won't do radioiodine in them. Excuse me. Or if they've had even a total thyroidectomy, but their actual tumor. So they may have a 4-centimeter nodule or a 3-centimeter nodule, but the actual tumor itself may be 0.5 centimeter or 0.8 centimeter. So it's really small. And if they don't have any of the other features which suggest invasiveness, that means that it's going outside the thyroid, then in that case, we don't typically treat with radioactive iodine.
Okay. Beth, do you have any thoughts on how doing a thyroidectomy may impact on giving iodine? I think sometimes, if I could lead the question, we see patients that we might have some sense that they may need it. How does that change how you would conduct your surgery, what you would recommend for surgery?
I'm not sure if this is what you're leading towards,
Yeah.
but the patients who have potentially metastatic lymph nodes, potentially larger tumors and extension outside the thyroid, those are things that sometimes we can either visually see intraoperatively or hopefully see preoperatively on our imaging studies, and can therefore kind of allow us to really advocate for a more sort of aggressive, if you will, type of surgery to evacuate as much tumor as possible. And then I don't know if Priyanka already said this, but there are certain types of tumors that aren't going to be responsive to radioactive iodine, right? So anaplastic, poorly differentiated medullary, et cetera, they're just not simply going to even take up radioactive iodine. So it also depends on what your biopsy showed in terms of the type of tumor that we're dealing with.
Exactly. Yeah. So we can't always tell if patients need iodine, but the things that Beth has mentioned are perhaps an inkling of what may be to come once the final pathology report is issued. Yeah. Daria, were there any other Q&As that were related to this this topic?
I think
you're
someone
muted,
had
by the
a
way,
question
Daria.
about
No, rookie move. Oh no. We're Daria, you're still muted.
How could I do that? I muted because I was typing some answers. So yeah, there's a few here that I think we could probably tackle. Like, how many times can you have radioactive iodine? And is there instances of increased risk of other cancers? And you know, sometimes we hear that, and is that somehow tied to radioactive iodine?
Maybe I'll veer clear of saying something idiotic and let Priyanka, the expert, mention what she thinks about this. So what do you think the max dose of iodine is? How many times can you give it? Those are the sorts of maybe more elementary answers that we can provide to our audience today.
Absolutely. So as per the guidelines, one can go up to 600 millicuries. So that's a huge dose. At a single time, we typically don't go beyond 200 millicuries. Historically, there were people who used to give even 250 millicuries of radioactive iodine. But nowadays, we are very, very cautious about how much we give. In terms of how many times can one person get radioactive iodine, that is debatable in the sense it depends on multiple factors. One is what are the other resources available to that patient? For example, if they are in a rural area, they don't have much access. And if it's a very small lesion or a nodule which has come back after surgery and radioiodine, and if the doctor, the best accessible treatment they have is radioactive iodine, sometimes they end up giving more radioactive iodine. But on the other hand, if you have access to other centers or where they treat thyroid cancer more, if you already have received radioiodine, then giving more radioactive iodine for some cancer which has either A, not responded at all, or if it has grown despite you getting a good dose of radioactive iodine, then there is no point in giving more radioiodine because it was not effective in the first place. Because remember, the goal of radioactive iodine is to reduce your risk for recurrence, and it has still come back. So in that case, you may need additional molecular testing. That means your doctor will need to test your tumor tissue for any mutations which your tumor might have, which makes it less responsive to radioactive iodine. And in that case, we can still give more radioiodine, but it has to be done following some kind of chemotherapy for a short time, which enables your tumor to take up the radioactive iodine. So when you go in with radioactive iodine the second time, it is really effective. And that's what we call in our medical terms, redifferentiation therapies. So yes, you can give more than once, but if there is a need to give more than once, then you definitely need more testing to make sure that the second time they give you, it is truly effective or it does its job. And to answer the other question about secondary cancers, so the reason there's a limit for 600 is because what we've seen is the higher you go with radioactive iodine dosage, there is a chance of secondary malignancies because of bone marrow suppression. One can develop lymphomas, leukemias, even aplastic anemia. So that's why we are cautious. And in fact, we do see some patients who say have received 2 doses of radioactive iodine, and now they are here and we are trying to do redifferentiation. We use something called dosimetry, which is a method by which we understand what is the maximum toxic dose for the bone, for the soft tissue, and then we determine that before we give our final treatment dose, because we don't want to exceed that toxic dose level. So there are a lot of safety mechanisms in place, and depends on what kind of center you go to, you will have access to those.
I definitely agree. It has a lot to do with the center. It also has to do with the generation or decade. What we used to do in the 80s, 90s, and 2000s, and made a lot of sense, is not something we do in the 2020s. And I also think even in the 2020s, one institution may be very gung-ho about radioiodine, give multiple doses, give higher doses. Other places would be more minimalist, maybe give lower doses or none at all. And again, I think it has a lot to do with philosophy, and they're all backed by evidence and science. It has just much to do with the principles and the perspectives of who's treating you. Mm-hmm. All right.
What about the damage to saliva glands? You know, the ones up here, the ones down here.
Right. Priyanka, maybe you could, I'm sorry, Mary, if you look. Oh no, are you waving your hands? No, waving away?
Yeah, I was
trying to advocate.
I wanted to jump in on that because
Yeah.
I think this is a very spirited discussion between the nuclear medicine doctors who give radioactive iodine and the surgeons and the patients, because there is some salivary issues with some patients, not universally. And I think all of us who treat thyroid cancer, no matter our specialty, do need to pay a little bit more attention to asking our patients about whether their mouth is dry or their salivary glands are swollen and tender. I do think that we may underestimate how many people have some at least temporary salivary symptoms with radioactive iodine. And it's not because the radioactive iodine is directly going into salivary cells. It's because there is the radioactivity in the salivary plumbing, the outflow of saliva. And I get involved in this because I do some of the procedures to help improve saliva flow, called silendoscopy. But I really wait until the patient has symptoms, because not everybody does. It is not a predictable outcome of radioactive iodine. And I look forward to hearing what Dr. Iyer has to say about that as well.
Well, you have a lot more experience, Mary, so I truly appreciate you sharing your experience and with that. So the normal doses that we use these days, and I can't speak for 80s and 90s, I wasn't there in practice at that time, but nowadays we use 100 to 150 for, a treatment dose for treating any residual disease in the adjuvant setting. Whereas if we are just trying to, get rid of the remnant or something that lights up on the scan, but may not necessarily be cancer, but just residual thyroid tissue. The dose might be less than 100. It might be anywhere between 30 to 50 millicuries. So we don't typically see any of those side effects at that low dose. Most patients tolerate it well. I haven't had a single patient yet who has complaints about the low dose. But at higher doses, above 100, you can have some dry mouth, some pain in the salivary glands. Some patients need a short course of steroids just because the radiation can inflame these glands. So we do sometimes give prednisone 5 milligram or 10 milligram, depending on how bad the symptoms are, just for like 5 to 7 days, and it resolves with that. But yes, certainly with higher doses, the risk is much high.
Right. These are under-recognized, perhaps underreported, but definitely quality of life factors to consider for patients that are going to be going iodine.
Absolutely.
All right, Dari, we've done really well so far. Now we're going to have some other questions, which we turn to the latter half.
Yeah, I'm just going to remind people that you can use the Q&A box if you want to tell us anything about your story. We won't answer those, but we'll look at them. And also remind everybody, if you go into the Q&A, you can look at the answered questions, because some of our doctors have been typing answers to some of you, which is so appreciated. And once they've been answered, you should be able to read those answers yourself if you're curious about that. So our fourth question, please help us understand some of these thyroid cancer related blood test terms, TSH, T3 and free T3, T4 and free T4, PTH and calcium, thyroglobulin and the thyroglobulin antibodies, and then calcitonin. I am going to move to the next slide because there's a nice graphic here that might help as you're answering, doctors. And then I left a little list reminder of all the things that were thrown into that question.
Ollie, this is a tough one. I mean, Priyanka, do you mind going through them
I can take a stab
elementary
at it.
basis? To be honest, I'll be very honest. I rarely get these when we see them before surgery, because many times the endocrinologist already has gotten them. So I'm going to let you take this if you don't mind, Dr. Iyer.
Absolutely, my pleasure. And please call me Priyanka.
Oh, Priyanka.
Yes. So TSH, as the name, TSH stands for thyroid stimulating hormone. And as you can see, thank you for the slide, Daria. This really helps. So the TSH is made by the pituitary gland, like you can see here. And that, as the name suggests, it's a hormone which stimulates the thyroid gland to make thyroid hormone, which is largely T4, and to some extent, a small amount of T3. And so what is T3 and free T3? What is T4 and free T4? So the thyroid gland, the pink structure that you see here, it is made of follicles or little pockets, which make the hormone or colloid, which contains thyroid hormone. And that is largely your total, it's thyroid hormone. And total T4 is the T4 that we measure in your blood. And what it entails is the thyroid hormone, which is circulating, bound to your blood protein, also called as albumin, and also that is free, that is not bound to anything. So when you see the term free T4 or free T3, what we are referring to is the actual thyroid hormone, which is not bound to any protein, and that is available to your body or to your organs for their basal metabolism. So that's why we check a free T4. We don't typically check a total T4 because it can vary. So for example, if somebody is very well nourished, their protein will be higher. So most of the hormone will be bound to that. Whereas on the other hand, in somebody who's sick or dealing with a chronic disease or is losing protein in the urine, their total T4 may not truly reflect their thyroid hormone because they may have a larger free component. So that's why we usually check a free T4 and TSH. Now, free T3 and T3 is the same principle. That being said, we usually check a total T3 because free T3 is not always stable in the lab. So it has to be tested within a certain time. I mean, it has to be run within a certain time. So a lot of physicians check a total T3. Now, in thyroid cancer management per se, we don't check a T3 level. It comes in more handy when you are treating Graves' disease or hyperthyroidism. For thyroid cancer surveillance, we usually go by TSH and free T4. And when we are checking for whether the dose is adequate or not, say a doctor has started you on levothyroxine or Synthroid or any other brand name, we want to see whether it is adequate or not. We go by the free T4 and TSH, mainly the TSH, because in thyroid cancer, with the help of thyroid hormone, we are doing two things. One, we are giving you the thyroid hormone that your gland would have made if you didn't have a surgery. And two, we are trying to keep that TSH at goal. And that goal is very individualized. It really depends on how your cancer looked like in the pathology and what is your goal TSH. Like for some people, it would be keep it in normal range. For some people, it would be a low risk, so you don't have to be as aggressive. So the free T4 comes in handy when we have to adjust the dose of thyroid hormone, as in how much do we need to go up? So to help you achieve that goal TSH or thyroid stimulating hormone. In terms of PTH and calcium, so those are, so PTH is a different hormone entirely. It is parathyroid hormone. And sometimes I wish they had named this gland something else. They always confuse our poor patients with thyroid and parathyroid, and a lot of patients use it interchangeably, and I don't blame them. It's the person who invented the name, I think. But PTH is parathyroid hormone. It's made by those 4 glands located behind the thyroid gland. And sometimes, go ahead, somebody spoke something? Okay. Yeah, so I don't know, is my voice breaking?
No, you're okay.
Okay, so parathyroid hormone is the hormone made by parathyroid glands located behind the thyroid, and they regulate the blood calcium level. So oftentimes we check that post-operatively, because if you've had a total thyroidectomy, that means if your entire thyroid gland is taken out, plus lymph nodes, or even if not lymph nodes, but just the entire gland, we want to make sure that your parathyroid gland was not injured during the surgery or accidentally taken out. And if it affects your parathyroid hormone levels, because that can cause the blood calcium levels to drop, and that can be really dangerous. Like, if it drops drastically, you might have some twitching, some tingling or shock-like sensations in your fingertips and toes, tingling around your mouth. And if you don't watch it, then, and if it keeps dropping, you can even have heart problems, like you can have arrhythmias, you could even have seizures. So a lot of bad things can happen. So that's why we check that post-op, immediate post-op, and then if it's normal, we stop checking that. But if it is still low, then we keep checking, and we as endocrinologists treat it. Now, coming to thyroglobulin and thyroglobulin antibodies, thyroglobulin is a measure of thyroid tissue. So it can be thyroid tissue, including what is thyroid cancer. Thyroglobulin antibodies are antibodies. That means, we all know antibodies are our body soldiers that fight infection or germs. But these antibodies are autoimmune. That means they are targeting your own thyroid gland. And a lot of patients tend to have these. So we check thyroglobulin and thyroglobulin antibodies together in those who have these antibodies present, because the thyroglobulin can normalize typically 8 to 12 weeks after the gland is taken out, but the antibodies tend to linger longer. It can take months or years, and sometimes a really long time, for those antibodies to go away. So that is important to monitor, because sometimes you may not see the thyroglobulin going up, but the thyroglobulin antibodies start going up, which tells us that maybe there is some cancer growing somewhere, and that's why we need to monitor them. And maybe follow it up with some kind of ultrasound or CT, depending on how high these antibodies go. Now, coming to calcitonin. Calcitonin is also a hormone made by the thyroid gland. Just in humans, it's vestigial is what we call it. That means it's not very functional, but that is monitored in patients who have medullary thyroid cancer, because those cancers make calcitonin, and when it's very high, it can sometimes give patients diarrhea and other symptoms like flushing, diarrhea, abdominal cramping. So the calcitonin level is a marker for medullary thyroid cancer.
Great. I think it's important, Priyanka, to jump off of what you said. Those last two, they are, quote unquote cancer markers, but they're imperfect. And I think I see in
Yes.
the Q&A that many times, it'll end up being 0 and then you'll see
Yes.
obvious cancer, and then the vice versa, right? So Priyanka, well, maybe in the interest of time, Daria, we'll leave it at that. But although they are useful markers, they're not perfect.
That is
Yeah,
correct.
there are a couple of questions there, but I think we could spend an hour just talking about that. So hopefully you've gleaned enough from this conversation, and we'll move on. Just a little ad here that we do have the 26th International Thyroid Cancer Survivors Conference coming up, October 13th through the 15th. You can join us live in Denver, Colorado, or you can join virtually. It's free. And just go to our link here, thyca.org/conference. It's all over social media, or you could scan the QR code, and hopefully you'll be with us. We don't have a lot of time left. We've got this question about thyroid hormone replacement. Please tell us about that, and how is a proper dosage determined?
So Daria, just so we know, I know the sixth question is also somewhat meaty. Just so we can maybe, because we've already talked about hormones and some of the labs already, maybe we should go to question 6, and because I think a lot of patients have that, and it'll just allow the other panelists to weigh in, because it is a interesting topic.
Okay, I will just remind people that we have this great resource called Know Your Pills, and you can get to that on our page. The last question: when do you use molecular testing? Afirma, ThyroSeq, ThyGenext. When is that used?
Yeah, maybe we'll let Beth start with this, her preference, her philosophy on these. Sometimes it's a very juicy topic, but sometimes a bit of a head scratcher for patients. What do you think, Beth?
So the times that I use these gene testing or molecular testing studies most frequently is actually in the case of indeterminate nodules. And I think there have been questions, we've kind of touched upon the fact that not every needle biopsy is a yes, it's cancer, or no, it's benign. There are quite a few, in fact, about 30% of all biopsies of thyroid nodules are going to come back as indeterminate. And this, the way I describe it to my patients is simply, they're funky enough that they can't call them benign, but they're not so funky that they have to call them cancer. So they're somewhere in between. They have some features that look abnormal, but they don't have all of the characteristics that we would use to actually qualify it as a cancer. So these go into a category that may have anywhere between a 5% risk of cancer all the way up to about a 40% risk of cancer. And it includes kind of two different groups of sort of classification systems when we're talking about what it looks like on a needle biopsy. These testing modalities have come about to help us try and sort of put these nodules, these gray area nodules, into a black or white category of either benign or cancerous. They are not perfect. They do not exactly do that. I wish that they did. It would certainly make our clinic visits a lot easier and faster discussions. But what they do is tell us whether or not there are mutations or fusions or potentially a sequence of genes that are turned on or off in a way that put a nodule and its genetic makeup in a higher risk for being cancer or a lower risk for being cancer. Most of these studies, just to kind of talk about them very broadly, will give you an approximate risk of malignancy. And none of these, I will tell you, will say 100%. 0 of them will say 100% this is cancer. They also will not say 100% this is benign. And so the risk continues to sort of, people, the companies are obviously trying to work towards those ends of the spectrum, but they are also not perfect. And so they can identify mutations that are targetable. And I think this is probably the other space where these testing modalities are used. When you know that you have a cancer, say, for example, one that might be more aggressive or more widespread, it may be very useful to use these tests to identify a molecular target for systemic therapy. So that would be, for example, in a patient who has metastases potentially beyond the neck, beyond lymph nodes, and into other organs, where they would need to be on some kind of chemotherapy or some kind of systemic therapy for their cancer.
Yeah, this is really kind of going into next generation type of treatments and decision making. Mary, what do you think between the three of them? Are they all the same? Is it 6 of one and half a dozen of the other? What do you think between the three, just amongst patients who are concerned that they didn't get the right test?
So that's a very important question. And in part, it is due to, in part, the choice of one of these three is based on a better understanding of how many of your patients with your pathologist who tell you they have indeterminate cytology findings. You have to understand what ultimately how many of those patients actually have cancer and those who don't. So that can help you choose one of the three. Secondly, all three are great. Afirma and ThyroSeq have the longest history in the market. I mean, because they are commercial tests. So those that have really good support for patients and support for getting results back quickly so that they can be used meaningfully is really helpful. That's part of customer service. And then ongoing surveillance of how accurate each one of these is. So I think any practice that chooses one needs to continue to survey how accurate the ThyroSeq answers are or the Afirma answers are in their practice. So if ThyroSeq comes back and says there's a 70% risk of malignancy, but the patient's ultimate pathology shows benign, just keep track of that. Try to understand better how each of these testing modalities apply to your practice. So I'm answering that without owning up to support for any one of the three.
Got it. Yeah. Other than Dr. Cottrell's fan club, I'm seeing that she's got some people in the chat that are following her into this webinar. I think we've all enjoyed everyone's very insightful comments. Daria, I want to make sure we end on time. I think we covered a lot of ground and had some very insightful explanations to some of these tough questions. What do you think?
We did, and this will be posted on our YouTube channel. I'll get it out there within a day or two. Watch social media for that link. And a reminder, we didn't get to everything tonight, but the conference is an opportunity. There's going to be 3 days of sessions, 5 tracks running each day, and multiple slots each day in the morning and in the afternoon. So somewhere is around 65 to 75 sessions, typical that will actually also be recorded. So please join us there. You'll have an opportunity to ask questions there in a similar format to this. So we're excited to offer that to you. I want to thank everybody, thank our wonderful panelists for this evening. And we're going to have another event coming up in December. So keep an eye for ads for that. And thank you, everybody.
Well, as we all like to say, all good things must come to an end. We really enjoyed having our panelists here, devoting an hour of their time, some very late in the evening, especially on the East Coast. We are very, very grateful and indebted to you. This is a great way to expand our reach, expand our expertise to patients that are, where it counts the most, right? Not just new patients, but also survivors. So thanks again for everybody for being willing to spend your time with us tonight.
Thank you.
Thanks so much, Alan, and thank you, Daria.
Thank you, Daria. Thank you, Alan.
You're welcome.
Thank you. Thank you to all the patients for attending. That was wonderful.
Hope to see you guys in Colorado. Thanks, Daria.
Thank you. Take care, everybody.